Good afternoon, everybody. Welcome to the latest session in CADI's COVID-19 webinar series. I'm Heather Logan, Executive Strategy Lead here at CADI. I'll be your moderator for today's webinar from Toronto, Ontario, Canada, which is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I want to thank the generations of people who have taken care of this land over the years. I encourage everyone participating today to think about where you're located and to give thanks to people who've been stewards of that land from the very beginning. So about our topic today, we're focusing on community-based aerosol transmission of the SARS-CoV-2 virus and HVAC systems, or heating, ventilation, and air conditioning, in other words, for systems that provide environmental comfort in homes and commercial buildings. We know that COVID-19 can spread when an infected person breathes out, coughs, sneezes, or talks, putting liquid particles into that carry the virus into the air, where it can potentially infect other people. We know that these liquid particles come in different sizes, larger droplets that fall to the ground, and smaller particles, sometimes called aerosols, that can linger in the air. We also know that particles carrying some infectious diseases such as measles, tuberculosis, and influenza can be spread through the systems that heat and cool buildings. This has raised concern. This history and our experience has raised concern that the same may be true of COVID-19 and the SARS-CoV-2 virus. As an organization that stands behind evidence-based decision-making here at CADI, we're pleased to be hosting today's webinar and to bring three great speakers to you. So for the webinar, we've brought these three experts who will outline what is known about the SARS-CoV-2 virus and how it's transmitted, and what the latest research shows about the potential role of HVAC systems, or heating, ventilation, and air conditioning systems, in spreading or possibly mitigating the risk of transmission. So let me introduce this wonderful panel. Dr. Jason Kinderchuk is an assistant professor in the Department of Medical Microbiology and Infectious Diseases at the University of Manitoba. Jason's research expertise and experiences have focused on emerging viruses, virus pathogenesis, and outbreak preparedness. He's actively involved in international outbreak response efforts, including for Ebola and COVID-19. Your second speaker, Dr. David Fishman, is a physician, epidemiologist, and professor at the University of Toronto. His research focus is on developing and applying novel methodological tools that allow physicians and public health experts to make the best possible decisions about communicable disease control. And the final panelist is Bill Dean, Vice President of ASHRI, a professional society with more than 55,000 members globally, including in Canada, who work in the fields of heating, ventilation, air conditioning, and refrigeration. Bill spent 27 years with the National Research Council of Canada, where he was responsible for site operations and facilities. His experience and education as a mechanical engineer make him well-versed in designing HVAC systems for a variety of building types. Each of our experts will come at the topic from a slightly different perspective. And by the end of the session, we should have a good understanding of the current state of evidence on the links or associations between HVAC systems and the transmission of SARS-CoV-2. I would like to make it clear that the focus today is on community transmission, not transmission through medical procedures or in hospital settings. Following all three presentations, we'll move into a Q&A session. You can submit your questions at any time by clicking on the Q&A button in the Zoom control bar, which is located at the bottom of your screen. Please let me know if you want your question to be directed to a potential or to a specific speaker. You can also use the Q&A tab to let us know of any technical issues you encounter, and CADI's events team will try and resolve them for you. So I'm going to hand it over to Dr. Jason Kinderchuk to get us started. Jason?
Great, thank you so much, Heather, and thank you to the organizers and again to all of you for participating in this today. I've come to you from sunny Saskatoon, Saskatchewan. I'm normally at the University of Manitoba, but I'm actually here at Vito Intervac for the next 12 months, helping lead some of our national COVID research response efforts. And really what I want to talk about is this idea of where we are with our current state of virological knowledge regarding transmission for COVID-19, and what we've been able to glean not only from experiences in laboratories, but also from data that we're now seeing. Next slide, please. For my disclosures, But listen, I'm an academic, so I have to disclose all my funding sources. That includes my Canada Research Chair position, a couple of CIHR rapid response grants that I'm on for COVID-19, as well as funding through INSERC and CFI and local funding agencies in Manitoba. Next slide, please. So the current state of knowledge of where we actually are in regards to SARS-CoV-2 transmission has certainly rapidly evolved over these past 12 months. And certainly thinking back to where we were in January and in that particular time when I was in Kenya, watching this virus emerge and trying to understand what the implications were for us in regards to droplets and aerosols and fomites and everything in between. So what we can do is we can glean somewhat of what we've been able to learn about past coronaviruses. In particular, when we look at differences in viral load kinetics, duration of infectivity, receptor binding affinity. And what we've been able to identify is really that SARS-CoV-2 seems to have a higher proclivity of binding to the ACE2 receptor in human cells than what the original SARS coronavirus did. But we're also seeing a much larger rate of community transmission than we've seen with either MERS or SARS coronavirus from the past. So it certainly indicates to us that, that this virus does behave very differently. And some of the work presented here in this figure very recently in Lancet Microbe from Dr. Muj Sevic gives us an idea of where we actually are in regards to what we understand about the transmission of infectious virus in relation to the shedding of RNA. What we understand right now is the actual isolation of infectious virus from samples from human patients has predominantly been from essentially day -2 out to day +10 post-symptom onset. We certainly see lingering amounts of RNA that is being expelled from patients. This is across different stages of disease severity, but that doesn't necessarily equate to infectious virus. So we know that at least we have a period where infectious virus seems to be being released from these patients. Then when we look back, what we understand about, about aerosols and transmission of small particle aerosols for other coronaviruses, we can look back at some of the information that we learned from SARS and MERS coronavirus, where they actually did look at air sampling within hospital settings to see whether or not they could actually isolate virus. In the case of SARS, they were able to get PCR positives on air sampling samples, but not necessarily infectious or culturable virus. MERS coronavirus, a little bit different. They were actually able to identify infectious virus in 4 of 7 air samplers that were tested. But it doesn't really give us an indication of what the role is in aerosols. So I think we're still, at a bit of a I guess, an intermediary stage and state of understanding how aerosols and droplets and potentially fomites all relate back to transmission. Part of this is also related back to the infectious dose. We certainly, I think, are still at an infancy in understanding what the infectious dose is for this virus. Prior estimations give us a bit of an idea for humans, at least based off some of the modeling studies for SARS coronavirus. But I don't think we truly know yet what it takes for a person to become infected. Is it 1 particle? Is it hundreds? Is it thousands? And then, of course, trying to link this back to the diversity of clinical presentation and outcomes is extremely difficult for us to do. Next slide, please.
Jason, it's Heather. We've had a few comments. You're a little bit hard to hear. Can you either move a little closer or turn up your volume? Thank you.
Sure. Hopefully this will be a little bit better. So when we look at droplets and aerosols, and I look back at what we are seeing right now in regards to the epidemiology of SARS coronavirus. The U.S. Centers for Disease Control and Prevention, up to October 5th, with their updates, we're still regarding the majority of SARS coronavirus 2 transmission to be primarily related to spread through close contact and not through airborne or aerosol transmission. WHO is falling in line with that, but they also are, I think, in a bit of an area where there is some debate in regards to how they look at droplets. So their definitions of droplets are anything that are greater than essentially 5 or 10 microns in diameter, whereas they consider droplet nuclei or aerosols as anything less than 5 microns in diameter. That has actually become somewhat of a contentious issue, but I think it's mostly a difference in language in how different researchers are actually speaking in regards to droplets and aerosols. And I'm hoping that after all this comes to rest with COVID-19, that maybe we will be able to find a common definition, because I think that's where really the miscommunication is. But we all obviously are seeing now more of a suggestion that aerosol transmission certainly can occur in certain circumstances. We've known that since the springtime, and I think we have a greater appreciation for this now, in particular with enclosed spaces, prolonged exposure, and adequate ventilation or air handling. And I'll point out Dr. Fissman and Dr. Marion Koopmans have a recent preprint that they just put up that I think is very eloquent in the way that it describes this idea of aerosol transmission, and in particular with the ideas about sizes of different droplets. Next slide, please. And where we are with this is, also this growing appreciation that aerosols do contribute. So certainly, Dr. Kim Prather and colleagues have suggested, that the definitions or the current definitions for droplets and aerosols don't necessarily fit what is the reality for how these behave from a physical science standpoint. And hopefully we will see some of that change. And I think we are moving certainly in that direction. Next slide, please. Now, when we look back at what has been kind of gathered for droplet and aerosol transmission data, the actual physical data is somewhat sparse. So when we look at some of the hospital data that's been gathered, and this was by Dr. James Lawler at the University of Nebraska, who thankfully actually I was able to work with for a few years in the past. They actually looked at doing air sampling in rooms with COVID-19 patients. Now, while they were able to demonstrate, first of all, that RNA persisted for lengthy periods of time, they were also able to identify that there was infectious virus in some of these samples. The issue that I think many people had brought up with the study was not at all about the techniques that were being used, but more so about the amount of infectious virus that was found. Certainly, they were able to identify it, but when they actually cultured that virus, there was very little cytopathic effect in the cells when they infected those cells. So that suggests that there was very little actual infectious virus. And this is where I think the debate still stands as far as trying to understand in normal situations or common situations, what are the true amount of infectious virions that remain in a particular room over time. And there certainly have been studies now as well that have looked in animals to try and identify this. Now, I will say up front, mice lie, hamsters, ferrets, and monkeys all exaggerate. So we have to understand that the studies where we look at transmission give us some indication of what may be happening in humans, but certainly are not necessarily the rule for what is happening. And in some of the more eloquent studies that have been done with ferrets, they've actually looked in this bottom figure of having basically an infected and a non-infected ferret put together in the same cage to look directly at contact transmission. But they've also had ferrets in subsequent cages that were separated by 10 centimeters. And what they were looking for was to see, with directional airflow moving from the infected cage to the non-infected cage, would they actually see a transmission event between those animals? And lo and behold, they did. The problem with this distance was that they still could not separate droplets and aerosols. So yes, it gives an indication that there is transmission, and the likelihood is that droplets and aerosols are both contributing, but it doesn't allow us to necessarily separate out what the actual benefit of either of those are, or the overall effect of either droplets or aerosols individually. Next slide, please. Now, a more recent study actually looked at this, and this was actually a study out of, I believe, actually out of the Netherlands. But they actually looked at trying to increase the complexity of these investigations. And what they did was essentially the same type of model, looking at ferrets and looking at the potential aerosol or airborne transmission of the virus from an infected to a non-infected ferret. But what they did is they actually separated the cages by about 1 meter in total distance using basically hard plastic tubing. And this tubing had a number of 90-degree turns in it. So the reason that the investigators did this was to try and show that, what was the actual likelihood that droplets would be able to transmit through that 1 meter distance to get to their non-infected cage mates. And they were able to show that, in fact, transmission still occurred, that with directional airflow, we were able to see that these infected animals were able to transmit. Now, what was interesting in the study is that they were ultimately able to show that they could still identify larger aerosols or droplets, so 50 micron diameter droplets at the entrances of both cages. So it suggests that, yes, we are getting, I think, to a better point in understanding what droplets and aerosols contribute, and that aerosols actually may be contributing more than we appreciated in the past. But we still can't fully delineate from an experimental standpoint what the overall activity or function of these are in transmission, at least from a laboratory setting. Next slide, please. So I think where we sit is really still trying to understand what our current knowledge gaps are and what things we have been able to gain an understanding of. First and foremost, I think we have to have obviously a more unified interdisciplinary standard of measurement for droplets and aerosols. I think that many of us are trying to say the same thing when we talk about this idea of infectious disease, but we have to start to understand that this is actually an interdisciplinary phenomenon. So I think, really need to work with our counterparts in physical sciences to be able to come up with a standard definition that takes into account what we understand, maybe from an infectious disease or from a biological standpoint, but merges what they understand in regards to this idea of droplet and aerosol transmission. And then, of course, we also need to start to accept that our risk assessments for aerosol generating procedures and probability of infection need to also adapt and change with newer information that's coming in. And I'll point again to Dr. Fisman's preprint that they put out, in that this is actually somewhat of a guidance for us to suggest where we actually are in regards to aerosols and aerosol transmission. We have to obviously still define the biological characteristics that underlie super spreading events. In particular, we know that super spreading events are overrepresented in transmission events for COVID-19, but trying to understand the true biological characteristics that underlie super spreading, I think we're still at an infancy in understanding. And of course, disinfection procedures for inactivation of infectious aerosols remain something that we still need to investigate and apply what we can in the laboratory. And in our considerations at the end of this, really what we're doing as far as infection prevention and control, we need to continue doing, but we also need to adapt with information. We certainly can't stay kind of locked in a particular position because that's what the science in the past has necessarily told us. This is a different virus, and certainly it's different times. And with that, I will end it at that, and thank you very much.
Thank you very much, Jason. Our next speaker is Dr. David Fisman. So David, I'll turn it over to you.
Great. Thanks so much. Is my volume okay?
Yes, it is.
Okay. So this is a title I've actually been using for a little while. This is I'm going to talk about this is Schrodinger's coronavirus version 2.0 because there's some new stuff in here. Could I get the next slide, please? So it's a bit of a play on the idea of Schrodinger's cat. Many of you will be familiar with this sort of thought experiment related to quantum mechanics, this idea that it's you don't know what you've got until you observe it. This idea that you could have a box with a cat in it, and the cat may be alive or dead and is in fact simultaneously alive and dead, but you only determine its state when you open the box. SARS-CoV-2 is a little bit of a Schrodinger's coronavirus, and we're sort of bedeviled by a couple of different paradoxes that make it very difficult to explain to people how they can change their behavior to protect themselves. Makes public health messaging challenging, and it also opens public health leaders up to sort of accusations that they're being inconsistent and so forth. So among the paradoxes with this virus, it's a highly virulent pathogen. It has an infection fatality ratio that's on a par with 1918 flu, but it also is characterized by a lot of asymptomatic infection, a lot of mild infection, particularly in kids and younger people, and by pre-symptomatic spread. It has a Pareto distributed reproduction number, which is what I'm going to focus on, this very skewed reproduction number where a majority of infections again and again and again in India and China, wherever this gets studied, about 80% of new infections come from 20% of old infections. That's called Pareto distributed. The implication of that is that most people are actually quite non-infectious, but then you get a minority of individuals who are highly infectious. And lastly, we have the paradox of this appearing to skip children and being very hard to see infections in kids. And indeed, when the pandemic started, there was the assumption that kids could not get infected. And now we see resurgences in a bunch of places driven by school opening. But I'll focus on the second bullet. Next slide, please. So the figure on the left is from February 2020. The figure on the right is from a paper published in Science last week. It's the same figure. These are diagrams made out of the sort of ball and stick diagrams made up of cases, index cases, and contacts, and the number of contacts that cases, number of secondary cases that have been generated by index cases. And what you can see, if you look over on the right-hand side there, which is a bit easier to see, is that a majority of cases actually don't transmit, and a minority of cases transmit a lot. And you can see that down at the bottom in the histogram in terms of number of secondary cases per primary case. This is Chinese data, very similar stuff from India about a month and a half ago, where most people are actually dead ends. So what we see when we see a reproduction number of 2 or 3, that's 2 or 3 cases, new cases per old case in a susceptible population, that's a weighted average of a lot of zeros on the one hand, let's say 80% zeros as here, with 20% of cases creating 1 or more new cases before they get better. In some cases in this diagram, making up to 10 new cases before they get better. So that 3 is a weighted average of, let's use 2. 2 would be a weighted average of 80% of cases creating 0 new cases, and 20% of cases creating on average 10 new cases. So when folks say, well, it's not airborne, it's not measles, well, it is measles on the one hand, sometimes alternating with something like MERS coronavirus. So you've got this MERS-like behavior where it's not transmissible at all in the community. But sometimes it basically is like measles with an extraordinarily high reproduction number. And we see that manifest in these remarkable super spreader events. I think we're at 100 cases in London in a healthcare institution. I'm not sure if that's a single exposure. I don't know too much about that. In London, Ontario, we've got these karaoke events. We've got these spin club events where very large numbers of secondary cases are created by an infectious primary case. Next slide, please. So we talk about this as overdispersion, and again, as you can see from the prior slide, where you've got that observation is there from February 2020. This was quantified. I think this is in March 2020 by Christian Altus and Julian Rieu in Switzerland. We talk about that as we describe that epidemiologically using an overdispersion parameter, which is usually denoted K. And the higher K is, the more overdispersed an R is. So what Julian and Christian have done here is they've plotted out some estimates for different coronaviruses and influenza viruses according to their reproduction number. That's the average number of new cases per old case, but also according to their overdispersion. And sorry, I think I flipped this around. So the higher the K is, the less overdispersed the pathogen is. So what you've got here with 1918 influenza is a much more homogeneous pathogen, where if you have a reproduction number of 2, that means that almost every case is going to make 2 new cases, 2 new cases, 2 new cases, 2 new cases. With a lower K over here on the left-hand side, like with SARS, you have the same reproduction number effectively. But this is, again, this idea of a weighted average, where lots of cases make no secondary cases at all, but some make a lot. That would be the idea with overdispersion. And could you just hit return again? Oh, no, that's backwards. There we go. So the take home for this is this has a couple of implications. One is it means that this is actually a controllable disease in theory and in many countries in the world in practice, because you don't need to find every single case in order to shut down transmission. You can miss cases because a lot of them are dead ends. Another implication is that when you import cases into a new locale, and we've seen this in Canada across the country, each individual imported case is unlikely to touch off an epidemic, and you need multiple repeated introductions with one of these causing a super spreader event before things take off. And that's this bottom figure from Adam Kucharski, sort of looking at probability of a large outbreak. And with an over-distributed pathogen, with a single introduction, the probability of an outbreak is low, but as you repeatedly flip that coin, eventually you're going to have an explosion. Next slide, please. And that's exactly what we saw in Ontario, where we had a number of case importations from January into Ontario, and nothing happened for a very long time. And I think that lulled many of us into a bit of a sense of false security. And then all of a sudden you're in it. And I think we likely in Toronto, I think we likely did miss a big super spreader event at the Mining and Metals Conference. But something happened in mid-March where we didn't have COVID transmission and suddenly we did. Next slide. So they've looked at this with phylogenetic analysis in Massachusetts. They've looked at their early transmission of COVID, and I'm not a phylogenetics expert, but it's fascinating when you're actually able to fingerprint these viruses. What they see is that super spreader events are really what touches off community transmission. And they had two very well described super spreader events in Massachusetts. One was at the Biogen conference. Another was, I believe, in a homeless shelter. And one of these things was contained and didn't go on further, and you didn't see onward propagation of that strain. And the other, the shelter-based outbreak, went on to cause outbreaks in a care home, and then subsequently, I believe, became the dominant community strain circulating in Boston, Massachusetts. So you can almost think of this with an over-dispersed are not, you can almost think of emergence invasion by an epidemic as trying to start an old outboard motor where you pull it 5 or 6 or 7 times, and on the 7th time you get an explosion, and all of a sudden you have a community epidemic, but the first 6 times you got nothing. And that likely relates very strongly to super spreader events, which I think my belief has evolved quite a bit over the last number of months. I believe that these are de facto large aerosol generated events. Next slide, please. So sources of heterogeneity, we opened the box and yay, Schrodinger's cat is alive. One more slide, please. So this is the preprint, which my name is on, but I have contributed very little to this. This is some brilliant work by a grad student at U of T by the name of Paul Chen, and his supervisors, Frank Gu, and the Faculty of Engineering here at University of Toronto. And it does bear a lot of similarity to Muget-Sevic's work on viral load. I'll just direct you to the top right-hand corner of the slide here. What Paul has done is, this is a meta-analysis. So he's gone and got viral load data by day from symptom onset. That's DFSO's day from symptom onset. And you can see that, like Muget, he's starting at -2 and going out to 10. And looking at viral load, this is an unculturable virus, this is PCR. And what he's able to do is sort of put together sort of a function that looks at what viral load is by day from symptom onset. And as Jason already mentioned, in these data, it looks like, you know, you've got things sort of taking off just prior to symptom onset. We think pre-symptomatic transmission accounts for about 50% of cases, peaking one day after symptom onset and then declining. And what Paul has done, which is really clever, is on top left here, I'll just show you what this is because it's sort of neat. You can see ABC. Paul's broken this down and actually done some meta-regressions on this, looking at, in panel C, viral load by symptoms or no symptoms, no difference. Viral load by age, adult versus pediatric, no difference. You can't even see 2 curves there. And then has looked at viral load in SARS-CoV-2 versus H1N1, where we have similar data. And what you can see is that blue curve is H1N1, which is a much peakier, sort of narrower curve than what you've got for SARS-CoV-2, which is the red curve, has a wider base, it's a flatter curve. And what that means is that you've got more skew at the high end in terms of very high viral loads among people who have high viral loads. So if you go 90th percentile and beyond in the SARS-CoV curve, you've got a lot more viral load, even if the average viral load is lower than with H1N1. You've got a higher viral load at the extreme. And the bottom panel here is showing that in an average, this is top where it says AB, in the top left panel, on average, an average case is shedding no viruses at all per respiratory droplet that they exude. And in the bottom, you can see the 98th percentile, where the x-axis here is the diameter of these particles that are coming out. And what you can see is you get a lot of viruses and very small respiratory particles coming out with some finite probability in folks who are at the 98th percentile. So next slide, please. And I'll try and hurry it along because I think I want to wrap up so we can have a discussion. So I think the answer to this question is yes. Can rare, this is 98th, 95th, 90th percentile, conditional aerosol transmission explain the 3 Cs? I think so. So disease stage and the activity of the infected individual, breathing versus singing, for example, may explain the spectrum of aerosolized virus. Different spectra of volume. This is from someone named Schijven in the Netherlands. You get markedly different volumes of respiratory secretions cast out into the air from the respiratory tract, depending on what you're doing with your vocal cords and your lungs, whether you're coughing, sneezing, singing, etc. And how many people are affected by that depends on what sort of setting you do that in. You know, is it crowded? Is it a prolonged exposure? Is it poor ventilation? Next slide, please. And back to Paul Chen. Paul, again, in this paper, which I won't go into in depth, but will recommend you all to, has sort of done some additional biophysical modeling, looking at different activities over on the right-hand side. Are you talking? Are you singing? Are you breathing? Is it a cough? Looking at the shedding of virions and what size droplets those virions come out in. And you can sort of transfer that over to the left-hand side of this figure and have a breakdown where, you know, aerosol, Jason had mentioned this, you know, the aerosol, this idea that aerosols are particles that are sufficiently small for people to infect via inhalation versus droplets, which are greater than 100 micron particles that are going to infect via ballistic transmission, where you actually have to splat someone in the eyes or mouth to transmit. The fraction of particles that are aerosol is going to depend on the activity. And then among aerosol particles over here in the purple, green, and yellow part of this diagram, that the fraction that are very small particles, for example, buoyant particles under 10 microns that can really stay suspended in the air for a long time, is also going to vary according to that activity. Next slide. And if you can just hit that twice, please. Hit return twice. So this again back to Schijven, and Schijven, very similar to Paul's paper. I'll skip over Schijven. You can see the idea here that different activities are generating different amounts of virus in the air in different sized droplets. How many virions you have in the bottom left depends on the viral load distribution. I think we're all independently coming to very similar conclusions. And then Schijven has sort of modeled this out as a quantitative risk analysis model, where they're looking at what you do with your vocal cords. And here they were modeling a Dutch bus based on ventilation. You know, you've got one exposed person is in that bus for 20 minutes. What's their likelihood of being infected based on what the index case does with their vocal cords? Next slide, please. And how does this translate to gatherings? And Carolyn Colleen, who's a brilliant modeler at Simon Fraser, has really done a lot to sort of characterize mathematically super spreader events for which there's sufficient data that you can sort of describe them. And I'll again recommend this paper to people, but I want to just read Carolyn's description of the events where they found that a lot of transmission was occurring. Transmission rates are highest for events involving sharing meals, singing and speaking, presumably at volume, though we don't have that information. Among the events we describe, the choir, birthday parties, call center, and lunch are the most saturated. That means the highest fraction of individuals. So there's this necessity of vocalization in order to infect a lot of the people who are at this event with you, which again strongly implies aerosol transmission. Next slide. and this again, this goes back some time. There's a wonderful group from Oxford, Trish Greenhall et al. Have been saying this for a while, that we need to overcome the 4 C's: closed, close, crowded, and continuous exposure with ventilation, and have this beautiful schema that I think many people will have seen that breaks down risk. Low risk is green, yellow is intermediate risk, and red is high risk, based on the occupancy of the setting, how much aerosolization you're engaged in. Are you shouting? Are you singing? Are you wearing face coverings? Are you not wearing face coverings? And how well ventilated is that space? And with that, I'll perhaps segue over to Bill. I think that's a good entree to Bill.
Thank you very much, Dr. Fissman. Bill, I'll hand it over to you, our third and final speaker.
Thank you very much. So now that we've kind of or set the stage with the understanding of where the aerosols are coming from, we're going to talk a little bit about the effects of air distribution systems. Next slide, please. So I represent ASHRAE, and ASHRAE is a large international organization that focuses on heating, ventilating, air conditioning, and refrigeration. And we have a significant number of Canadian members. This guidance is available across the country from ASHRAE members. Next. So ASHRAE is committed to participating in events like this one to ensure that we're interacting with people who are interested in these subjects, where the built environment is a significant factor in relating to these various kinds of events. And ASHRAE does develop standards and guidelines that we use to influence the built environment. Next, please. So what is the current state? We've talked about aerosol dissemination, but there are a few baselines that we need to understand. That they're in the indoor environment, infectious aerosol dissemination is impacted by the distribution patterns of the air moving around the space. It's influenced by differential pressurization. It's influenced by source capture, and this is more common in different kinds of maybe healthcare, but laboratories, different things like this where air is directed. It's heavily influenced by air filtration, and there is evidence to show that temperature and relative humidity will influence the survivability of different aerosols. Next. So the one absolute is that general dilution, ventilation, and pressure differentials do not significantly influence short-range transmission, which is essentially saying that if you have droplets or you have somebody breathing heavily and they're close together, short of a windstorm in the space, you're not going to significantly influence the transmission between those people. That airflow direction can create clean to dirty flow patterns, but we need to fully understand how that whole situation works. So next. Small infectious particles can include droplet nuclei that are resulting from desiccation of the droplet. So if somebody expels a large, and the numbers that within ASHRAE we tend to use are 100 microns for the and larger for droplets. So those droplets can, in a very dry environment, tend to evaporate and then become an aerosol and remain airborne. So they don't tend to settle out unless they're smaller than about 10 microns. Next. So we recognize that the most robust HVAC systems are not going to be able to control all the airflows within a space, and that there's a lot of other factors within a space, heat sources, fans, different pieces of equipment, the barriers that you'll place within a workspace or a home or wherever you are that will create changes in the way the air flows around those. So the impact of a system is really going to be depending on where the inlets and the outlets are of air into that space, how hard, how much velocity the air is coming in and out of in that space, and of course the distribution of any aerosols within that space. The temperature and relative humidity, as I've talked about, are going to have an impact. Less temperature, more relative humidity, but filtration is going to have a major impact on the distribution of those aerosols. And within ASHRAE, we've got 3 different standards that deal with these specific issues. Next. So we recognize that the role of the HVAC engineer is a part of a larger effort that involves people from all sorts of different fields, from the designers, the owners, the operators, the hygienists, and the infection prevention specialists. All those pieces of knowledge and experience must be combined to create this stronger rope to produce solutions that work for the space that you're talking about. Next. So with specifically with COVID-19, ASHRAE developed a series of resources, a web page, the web address is there, and we created the Epidemic Task Force to bring together all of the best minds that we could pull together that dealt with these specific areas. And so we have resources that are available. We talk about different buildings and building types that might apply to different organizations. We have guidelines that are specific for schools, healthcare, multifamily facilities, residences, and commercial. So if you go to this website, you'll get very specific information on these, including transportation. We've already talked about the bus spread, but planes initially were seen as one of the primary vectors for the distribution of these diseases. So there's guidance on what you can do to counteract some of those effects. Next. So with specific strategies, filtration is the one thing that we have. Okay, evidence level A, just start there, means that there is absolute proof that these methods work. Evidence level B is that we have a high confidence that they work, but it's not quite absolute yet. So enhanced filtration over code minimums definitely has an effect on the aerosols. If you have really good filtration, you will remove a lot or most of the viruses from the air. Ultraviolet germicidal irradiation can be used as a supplement to airflow and has been used for a long period of time, not always for this application, but is being increasingly chosen at this point in time. Personal ventilation systems are going to work for certain high-risk activities. So again, this is typically something like, well, the portable freestanding high-efficiency unit. So if you have an application where you're concerned about the spread, HEPA filter, just recirculating the air is going to help to capture any particles that you have. And of course, what we're seeing is that humidity levels above 40% tend to cause the virus to be less survivable over a longer period of time. Next. So what do we suggest? Increasing outdoor ventilation so that the corollary is actually the truth here, that we're recirculating less air through a space. So if in the past, in the winter time, that you're recirculating 80% of the air, we suggest that you try and reduce that number to bring in more fresh air. That you increase the filtration on your filters to at least the MERV 13 level or the highest available, and I'll dig into this quickly in a moment. Keep your systems running longer if you can. A lot of these strategies are going to add to energy costs, so there needs to be a little bit of a balance. We talked about portable air cleaners and UVG devices. So the bottom item here is if you have a bypass energy recovery or if you have an energy recovery ventilation system, make sure that there's no way for the exhaust air, the warm air from the building can be rerouted through those devices sometimes. Make sure that there's really good seals, so that's as much a maintenance item as a strategy. Next. So we're going to go through just a real quick example. If you had an air handler that was around 10,000 liters per second and it had MERV 8 filters and you wanted to upgrade it to 14, you find that the pressure drop, the initial pressure drop is a little higher for the MERV 14, but it's a lot higher when the filters are dirty. So you need to make sure that your air handlers can handle that. Next. So in this quick chart here, you see that the static pressure, which also includes things like the coils, the ductwork, louvers, dampers, all this other stuff. For the MERV 8 example and sort of the as designed clean situate, or this is actually with the dirty filters, has 1325 kilopascals and consumes about 4.1 kilowatts when the system is running at full capacity. When you put MERV 14 filters in and they get fully loaded, you're going to see 1 kilowatt of additional load on your fans. Now, as you approach the motor size, you may actually find that if you put a MERV 14 filter in, that your motor won't be able to handle that. You'll have less maximum supply air. And this is, in most parts of Canada, it's only an issue in the summer, but it just shows you that it's not as simple as just running out and buying a bunch of filters. You need to understand what the impact is going to be on your system. Next. So in UVGI, there are two different ways that you can look at this in the application. If you have very high ceiling areas and the air is circulating in the space, you can consider installing units that will expose any of the aerosols to the UVGI lights. And it doesn't take a very long exposure, 2 to 3 seconds is enough. But you need to make sure that the air is circulating through that space and that there's not a lot of other organic material in that upper area. If you have a low ceiling area, you want to make sure
I think Bill's system may have crashed on him momentarily. So this is Heather Logan. I'm just going to thank Jason, Bill, and David for the incredible presentations. If Bill does come back online, I'm sure he can finish his last slides for us quickly. So for everyone in the audience right now, I just want to let you know, and I know we've got 30 or 40 questions that have come into the Q&A system on the bottom. That's please how you'll submit your questions. I don't know, Bill, are you back?
Can you hear me?
I can. Would you like to wrap up in a minute or less, please?
Yes.
Welcome back.
Okay, well, yeah, thank you. So let's go on to the next slide. This is just another application of the same technology, and just shows that if you're concerned about the viruses plating out, or if you're concerned about mold growth, this is a typical application. Next slide. So if you are considering any kind of building setback, there's a number of checklists that we suggest. A lot of them have to do with the automated building systems. But again, a lot of this kind of guidance is available from that website. So I think that's it for me. Thank you very much.
All right, thank you very much, Bill, and thank you again to the three speakers. They're terrific presentations. So we've had a few questions come in ahead of time and several in the chat box. We will not have time for all of them. I'll go through them fairly quickly. So if I address each of the speakers, if you could respond as quickly and efficiently as possible, to help us get through the volume of questions that we have. So first question that came in online is from an infection prevention control practitioner in a hospital in the GTA area. I think this question is probably for Dr. Fissman and then potentially for Bill. If you could please discuss the issue of community areas such as fertility clinics, standalone surgical units, family health teams, and potentially daycares. Some of these settings exist in rented office space that have standards for clerical offices, but not necessarily for the kind of services that are actually being provided there. Is there any guidance or information that would help to support their information needs or those settings? Dr. Fissman first and then Bill.
Sorry, if I understand this correctly, is there anything to do about prevention of transmission in settings that aren't really ventilated, like hospitals are ventilated?
Correct.
Yeah, it's tough, right? And you see this with schools as well, because our schools, a lot of our built structures, our skyscrapers, our schools aren't really built anymore to be well ventilated spaces. With the bigger buildings, a lot of that reflects building practices in the 70s and 80s, where the concern was about locking heat and air conditioning in rather than about getting fresh air in. So what can you do? Because it takes a while to revamp the HVAC system in a big building. Portable HEPA filters are one thing that you can do. CO2 monitors that run about $120 for a good one will tell you whether or not that space is well ventilated. And then masking. I think there's a lot of misunderstanding of what masks are about, and that's led to, as if you're in IPAC, you know this, that's led to a lot of angst about the limited N95 supply. What we're thinking about with masks and aerosol is we're thinking about preventing generation of aerosol by infectious cases who maybe don't know they're infected yet, as much as we're thinking about, filtration of the air that you're breathing in if you're an uninfected case. So universal masking is really helpful. We've had some, sorry, and I know I'm supposed to keep this short. This is the last thing. It's important though. So and I think there was a question in the chat about barriers, like plexiglass barriers. Aerosols, smoke's an aerosol, cigarette smoke's an aerosol. I don't know if anyone else is old enough to remember the VIA trains where they had a smoking section and a non-smoking section in the same train car, and they were separated by plexiglass that went up the middle of the train car like to about chin height. That did absolutely nothing because smoke's an aerosol. So in some of the hospitals in the GTA, there are folks who have clinics and there's a piece of plexiglass there and the person behind the plexiglass isn't masked. Well, the plexiglass isn't going to do anything about aerosols if you think about it as being like cigarette smoke. So having folks masked on both sides of that plexiglass barrier is a very important thing at all times. And obviously figuring out where you go to eat and drink, because that's become a vulnerability because you can't get food in with a mask on.
Thanks very much, Dr. Fissman. Bill, did you have anything you'd like to add to that?
Well, it's critical that you understand how your air is moving through the space, and as David suggested, the flow of air is influenced by so many different things that it really does come down to a case-by-case study and understanding how that air is going to be flowing through the space and how it's influenced by heat sources, cooling sources, sunshine, all sorts of other things.
Great, thank you. Jason, I'm going to direct the next question to you. It probably could go to either you or Dr. Fissman, but we'll direct it to you. During the pandemic, researchers have discovered new mutated strains or variants of SARS-CoV-2, the virus that causes COVID-19. How many mutated strains are there? Do we know? And can you comment on the effect of the variants on viral spread?
Yeah, so in regards to mutations, listen, these are RNA viruses, so they mutate all the time. The benefit for us is that with coronaviruses, they have basically a spell check option on their Word document as they replicate. So they're able to actually make corrections, and that actually limits their ability to mutate very frequently. Now, that being said, we've seen certain mutations that have taken over. The D614G variant certainly took over in Europe and in North America, and we've seen a discussion about new variants that have taken over Europe in the second wave. There's been some data to suggest that the transmissibility may actually be increased on this new variant, but we haven't seen necessarily a link to virulence. And I think that's the important point is, yes, there's some data, at least from the laboratory, to suggest that, yeah, maybe we're seeing some shifts, but we haven't seen that rampant shift that has changed what we've seen in terms of clinical disease in this virus. In particular, even in the animal models, there's been some discussion about potential changes, but nothing that would certainly change, I think, what we need to do in regards to our own personal protection. And as well, when we think about vaccines or therapeutic design, we haven't seen anything that at least leads people to be concerned about impacts.
Great. Thank you very much, Jason. So the next question, Bill, is for you. Are there indoor environments where UBGI is not appropriate? And what is the best guidance to follow? Is it from ASHRI? Are there other resources available for using UBGI?
Oh, yeah. There are a lot of different resources available, and it's a fairly easy search to find all the various information that's available out there. The different manufacturers will provide guidance, so there is no one ultimate source of information, and a lot of it is dependent on the specific type of application that you have. So that, yes, there are a lot of applications that are not appropriate, so it really is incumbent upon the when you are considering this to understand what the limits are, and there are a number, so I won't go into detail at this time, but yes, consult with an expert.
Thank you very much. Unfortunately, I know we have questions we have not answered, and they are all important. They'll be flagged here, and we will try and address them in future correspondence or webinars on this topic. I do, because it's important to leave the final word with the speakers to really what is the key thing that we'd like to wrap up. So before we go, each of the speakers in about 30 seconds, if you could please, if you want people to remember one thing from your talk in today's webinar, what would that be? And I'm going to hand it over to Dr. Kinderchuk first, please.
Listen, I think that the easiest way for me to say this is probably more from the 30,000-foot view. We're not through this. Certainly, we have heard the amazing announcements about the Pfizer and Moderna vaccine. We are getting close to potentially having some change back to normalcy. We have a long ways to go. And in looking at the cases in Manitoba and Alberta, what's been going on here, even in Saskatchewan, we have to keep up doing the things that we know work. We are going to continue in the lab to try to figure out what this means, but please just continue to do the things that are working in regards to prevention.
Thanks very much, Dr. Kinderchuk. Dr. Fissman.
Yeah, I'm going to channel Mike Ryan from the WHO because I couldn't say anything better than what he's said. I think his two key points that he keeps reiterating are: one, it's a pandemic. We've all been wrong. It's a new pathogen, and you must keep an open mind. And ideas that seem weird or upside down, or which are contrary to, what we've all been learning for the last 20 years, are not necessarily wrong ideas. This is a new situation, and it's important not to get too anchored to, what you think you know. His second point that he's hit on again and again and again is the importance of acting even when you're uncertain. That the worst thing you can do is sort of stand there overthinking and doing nothing. And I think the aerosol's been an example of that, where, for example, we had very painful evolution on masks here in Ontario that was sort of kicking and screaming every inch of the way. Whoever ultimately turns out to have been right or wrong on that, the costs were so low and the benefits potentially so high that it didn't make any sense to argue about that for months. So I think, time is of the essence here.
Thank you. I think we have lost Bill, so I'm going to take a minute to say thank you and to close. That brings us to the end of today's session. Really a big thank you for our three speakers who are busy dealing with COVID-19 and gave us time today. There will be a short evaluation survey open in a new window when you exit. Please fill that out if you can. It helps us improve and make these better. In response to a number of questions, yes, this presentation will be posted on CADA's YouTube page later this week. We will be back in the new year. We've got a couple of webinars already planned on COVID-19 that I know you'll want to listen to. And don't forget to check out our virtual symposium. There were a number of great talks there about COVID-19, of course, many others. And as always, in the middle of the pandemic, please continue to follow good public health recommendations, wash your hands, wear a mask, and stay safe. Have a good holiday season and see you in the new year.